afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on the impact of the COVID-19 pandemic on routine immunizations in Alberta. My name is Diane Liu, and I'm a public health physician at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin with today's presentation, I'll mention a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have any questions during the session. A discussion and question period will follow the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would like to state that as the moderator of the session, I do not have any potential conflicts of interest to declare. Please note, while this session is being recorded, the posting of the recording will be delayed until further notice. It is now my pleasure to introduce the speakers for today's presentation, Dr. Shannon McDonald and Mr. Yuba Raj Padel. Dr. Shannon McDonald is an associate professor in the Faculty of Nursing and an adjunct assistant professor in the School of Public Health at the University of Alberta. Dr. McDonald's program of research focuses on vaccine hesitancy, uptake, and safety, with an emphasis on supporting immunization best practices and policies. She has a particular interest in addressing system-level barriers and supports to achieving high immunization coverage, especially in underserved populations. Mr. Padel is a PhD candidate at the School of Public Health, University of Alberta. He is currently working as a data analyst under the supervision of Dr. McDonald. His interests include global health, health systems, health disparities, and preventive medicine. Now over to the speakers.
And Yuba and I are speaking to you today from Edmonton, the traditional lands of First Nations and Métis people in what is now known as Treaty 6 Territory and Métis Region 4. And I feel really blessed to live in this beautiful land that has been the home of Indigenous peoples long before my family arrived here. So the obligatory slide that says, well, I'll let you read it. PHO is not the owner of the content, etc., etc. And then we will launch into the presentation. So the plan for this session is to cover a few things. So the information we're going to share is based on work we've conducted in Alberta on the impact of the pandemic on routine immunizations. Certainly, much attention is being focused on achieving high uptake of COVID vaccines, but I would argue that it's equally important that we not forget the routine vaccine programs that have protected us from diseases like polio, measles, and pertussis, amongst others. We certainly don't want to put ourselves into a position where we emerge from this pandemic only to be faced with outbreaks of other vaccine preventable diseases due to low uptake of routine vaccines during the pandemic. And that is a very real possibility, given that coverage levels for many of these vaccines were barely high enough to maintain community protection before the pandemic. Any significant drop in coverage as a result of the pandemic, when combined with the removal of public health restrictions, the return of international travel, etc., could result in importation and spread of any number of infectious diseases. So today we're sharing with you results from our analysis of early childhood and early work on school-based vaccines in Alberta. Other ongoing work by our team includes similar work in other provinces, as well as more in-depth analysis of school vaccines. So we're going to cover briefly, just remind us all of the timeline of public health restrictions, because they do vary a bit province to province. Talk over the recommendations about routine vaccine delivery, and then Yuba will share with you our findings regarding infant immunization coverage, comparing the pre-pandemic and first pandemic year. And then I will return to give you a brief glimpse at our initial work on school vaccine coverage and strategies that have been used to catch up both these programs. By the end of the session, we hope you'll understand the extent to which routine vaccine coverage declined compared to the pre-pandemic period, understand whether those who have missed getting vaccinated during the early pandemic were caught up later, and understand some of the strategies that are adopted in Alberta that may be useful elsewhere. I'm sure most of us don't need to be reminded of this, but it seems like only yesterday in some ways and a decade ago in other ways. So just to map this out for everybody, the pandemic, of course, began and was declared a pandemic in March. And then shortly thereafter, public health emergency was declared in Alberta. And then moving into some of the restrictions, and this, the reason we're sharing this is particularly because you'll see some patterns in the data around vaccine coverage that reflect some of these. So for instance, we have here the first wave of the pandemic starting in March 2020, in which public health restrictions started. They eased somewhat in May, and some businesses began to reopen. And we had a second wave that arrived in October, November 2020, and a number of public health restrictions were reintroduced and a lot of schools closed at that time. So there were a number of recommendations that came out, fortunately, quite early in the pandemic. So there was a lot of work done by provincial and national bodies to ensure that there was a real awareness about strategies to maintain the continuity of routine immunizations. And particularly, they prioritized the primary immunization series for infants, with some modifications, of course, to immunization services, such as shorter appointments that focused only on immunization, use of personal protective equipment, and social distancing. In the school age program, most provincial and the NACI statements stated that routine school age vaccines could be deferred until schools reopened, and that restarting a series that had been interrupted wasn't necessary, that we just pick up where we left off. In Alberta, there was an explicit rule that eligibility criteria should ensure that students who missed immunizations due to school closures would remain eligible. So for instance, if they would have normally aged out, they would remain eligible until they could receive the vaccine. And there were a number of reminder or recall processes that were recommended to ensure that children received immunizations after schools or health services resumed. So now I'd like to tell you a bit about the project that we're reporting on today. This was funded by one of the CIHR COVID-19 rapid research funding opportunities, and it was augmented with a grant from the Canadian Immunization Research Network. And the project included researchers from 6 provinces, including in Ontario. I'm not sure if any of our co-investigators are on the call today, but we had great representation. Our knowledge users are a key part of this. The Secretariat for the National Advisory Committee on Immunization were key knowledge users, and then we had provincial public health officials in Alberta, Quebec, and BC who were knowledge users on the team. And just to give credit to the folks who've been involved in this, these are all the researchers from across Canada that were involved in, or are involved in the project, and the knowledge users by name. I think it's important to give them credit for all the fact that they put time into this in the midst of everything else they were doing is much appreciated. So the project, which we call the Thekovim Project, is a multi-method national study that incorporates data from 4 complementary approaches. The first was an environmental scan to understand what the provinces were doing to maintain continuity of routine programs, as well as roll out COVID vaccine programs. And both of those areas we've published manuscripts on if anyone's interested in. We have 2 cross-sectional pan-Canadian surveys, the second of which is in the field right now. We're doing interviews with members of underserved populations to understand what their particular barriers might be. And then what we're focusing on today is analysis of routine vaccine coverage data in 3 provinces. So today we're just going to be talking about this last activity in relation to the province of Alberta. And I'm now going to turn the presentation over to my colleague, Yuba Podol.
Thank you, Shannon. Good morning, everyone. Now I'm going to talk about the impact of COVID-19 pandemic on infant vaccine coverage in Alberta. You can see this is the infant immunization schedule in Alberta, and in the current analysis, we are looking at 3 vaccines: measles, rotavirus, and pertussis containing vaccine. We are not including meningococcal and pneumococcal vaccines here. Pertussis containing vaccine, which is given 4 doses at 2, 4, 6, and 18 months. Rotavirus vaccine given at 3 doses at 2, 4, and 6 months. And for measles vaccine, we're including just the first dose given at 12 months. And talking a little bit about the methods we used for this analysis. We use administrative data available from Ministry of Health Alberta for this analysis, and data were extracted in May 2021. We define vaccine coverage as the proportion of age-eligible children who were vaccinated by 1 month past their due date, and we included the day they turned 1 month past their due date to calculate this vaccine coverage. We used monthly coverage to see whether children received timely vaccination, and also looked at the cumulative coverage to investigate whether those missed to get vaccination by 1 month past their due date were caught up later. And we calculated coverage difference, so 2020 coverage minus 2019 coverage, and also calculated 95% confidence interval of that difference to see whether 0 was included in that confidence interval to assess the statistical significance of the difference. And for cumulative coverage, we examined the overlap in 95% confidence interval of the actual coverage at the point of reference. And during the analysis, those not respecting the minimum and maximum age to receive the vaccine and not respecting a minimum interval between 2 doses are excluded from coverage calculation. So first of all, this is the this graph is showing difference in monthly coverage for measles containing vaccine between each month in 2020 and 2019. Here, y-axis is showing the absolute difference in vaccine coverage between 2020 and 2019. So we are graphing coverage in 2020 minus 2019. In other words, if the difference point is at the middle or 0 line, which is the line of no difference, then the 2020 coverage is same as 2019 coverage for that month. If the difference line is above the middle 0 line, then it means 2020 coverage was higher than 2019. And if it's below the 0 line, then 2020 coverage is lower than the 2019 for that month. And x-axis is showing the months we are comparing. And along the x-axis, the bolded months indicate that coverage significantly differed between the corresponding months in 2019 and 2020. So when we look at the graph, we can see that in January and February, the first 2 months, the difference line is above the middle 0 line. That means 2020 coverage was significantly higher compared to 2019, just before the pandemic started in Alberta. As the pandemic started, so starting from March, the coverage in 2020 starts to decline and the difference started to be negative. And it was significantly lower in April and May 2020 compared to corresponding months in 2019. As the pandemic restrictions loosened, the coverage in 2020 increased and almost reached to 2019 level between July and October. And as the second wave of the pandemic was observed and restrictions were again put in place, we can see that the difference became negative again. Significantly lower coverage in 2020 compared to 2019, and highest here we can see that highest decline was observed in the month of April, where there was a 10% lower coverage in 2020 compared to 2019. And next, this is the similar coverage difference graph for 3 doses of rotavirus vaccine. And the superscript letters here in the along the x-axis in the months indicate that which dose had a significant difference in coverage between 2020 and 2019, because we are including 3 doses of rotavirus vaccine in the same graph here. So if superscript letter is A for that month, that means there was a significant difference for the first dose. If there is a superscript letter B for that month, then there was a significant difference for second dose, and C means there was a significant difference for third dose. Again, in this graph, we can see that in January and February, the difference line was above the middle 0 line. That means 2020 coverage was higher compared to 2019. And as the pandemic started, the difference became negative, and it was significantly lower in April and May 2020 compared to corresponding months in 2019. However, third dose was an exception here. In May and November 2020, coverage for the third dose of rotavirus vaccine was found to be higher compared to 2019. And personal communication with public health managers revealed that after initial reduction of vaccine service delivery at the start of the pandemic, many community health centers were contacting parents of 6-month-old children to get them vaccinated before they age out of rotavirus vaccine eligibility. Because third dose has an age limitation that it needs to be given within 8 months of the child's age. That age limitation might have led to the heightened efforts to vaccinate for the third dose. And after initial reduction, coverage for other doses increased July onwards and remained similar to 2020 level. This graph is showing 4 doses of pertussis containing vaccine, and we are comparing between each months in 2020 and 2019. Again, the bolded months indicate that coverage significantly differed between the corresponding months, and the superscript letters indicate which dose had a significant difference. So A for first dose and D for fourth dose. And this graph is pretty much follows the trend observed for rotavirus vaccine. Coverage was higher in 2020 compared to 2019 before the pandemic started, significantly declined as public health restrictions were put in place. And as the pandemic restriction loosened, the coverage in 2020 increased and almost reached to 2019 level from July onwards. And again, third dose was an exception here also, which showed higher coverage in May and November. So the scheduling of rotavirus third dose and pertussis third dose is together. So again, and for fourth dose, for which the coverage significantly declined after September. So together with the second wave of the pandemic, and comparing 4 doses of pertussis containing vaccine, we can see that fourth dose given at 18 months showed the highest decline among the 4 doses. So it showed 9% lower in September and 13% lower in November and almost 10% in April. Now we are going to talk about the cumulative coverage. Our objective here was to investigate whether those missed to get vaccinated within 1 month of their due date were vaccinated later during 1 year of follow-up. And we selected here only March and April cohorts because these cohorts had the greatest impact on cumulative coverage compared to other monthly cohorts. In this slide, the left graph is showing the cumulative coverage for March cohort, and the right graph is showing the April cohort. So first of all, if we look at the graph on the left side, y-axis is showing the cumulative coverage in percentage, and x-axis is showing the number of months followed up until. So for measles vaccine, we follow up from 13 months until 25th month of their life. So in this graph, that solid line is for the cohort who reached 13 months in March 2019, and gray line is for the cohort who reached 13 months in March 2020. So we can see initially at 13 months, the coverage were similar at 13 months for the March cohort. However, for March, so if we look at the dark line for March 2019 cohort indicated by the dark line, those missed at the 13 months would have received vaccine in 14, 15 months and so on in 2019. But chances of vaccination in subsequent months was significantly lower in 2020. So, and we can see that since the 95% confidence interval are not overlapping even at the 25th month for March cohort, and the gap in cumulative coverage is 5% is at the end of follow-up. And for April cohort graph on the right side, there was a 10% difference at the initial 13 months and a 5% difference at the end of the follow-up period. That means a significant proportion of children, and we can see that the 95 confidence intervals are not overlapping. That means a significant proportion of children are still left behind to get vaccinated at the end of the follow-up compared to 2019 for both March and April cohorts. Now, this graph is comparing cumulative coverage for the first dose of pertussis containing vaccine. And we started follow-up from 3rd month and followed up them until 15 months of their life for the March cohort. And if you look at the graph on the left side for March cohort, there was no significant difference in coverage at the start of the follow-up and also at the end of the follow-up. For April cohort shown in the right side, we can see that although a lower proportion received vaccine in April 2020 compared to April 2019, there was a 5% difference. Those missed earlier are caught up later, and the cumulative coverage difference is not significantly different at the 14th month. So there is a gap of 1%. Now, this graph is comparing cumulative coverage for 2nd dose of pertussis containing vaccine, and follow-up for 2nd dose of pertussis containing vaccine starts from the 5th month until 17th month of their life. And at the end of the follow-up, if we look at the March cohort on the left side of left graph, there were significantly lower proportion of children vaccinated in 2020 March cohort compared to 2019 March cohort at the end of the follow-up, and we can see there was a difference of 3% between the cumulative coverage. And for April cohort shown on the right side, a significant proportion of those missed earlier are also still left to be caught up, and the cumulative difference coverage is significantly different at the end of the follow-up at 16th month. Now, for this graph is comparing cumulative coverage for 3rd dose of pertussis containing vaccine, and follow-up for 3rd dose starts from 7th month until 19th month of their life. For the March cohort, who turned 7 months in March 2020, coverage was not significantly different compared to 2019 coverage, both at the start and the end of follow-up. And for April cohort, there was a significantly lower coverage in 2020 compared to 2019 at the beginning of the follow-up. And those missed earlier are caught up later, and the cumulative difference was not significantly different at the end of the follow-up. This might be due to increased attention to receive rotavirus vaccine. So due to that increased attention for the 3rd dose, there was no difference. Now, this graph is comparing cumulative coverage for 4th dose of pertussis containing vaccine, and follow-up for the 4th dose starts from 19 months until 31 months of their life. And for children who turn 19 months in March, as shown on the graph on the left side, 2020 coverage was not different at the start of the follow-up and as well as at the end of the follow-up. For April cohort, there was a significantly lower coverage in 2020 compared to 2019 at the beginning of the follow-up, and there was a 9% gap. However, at the end of the follow-up, those missed earlier are caught off, and at the end of the follow-up, there is about a 2% gap. And here in this cumulative coverage assessment, we only presented measles and pertussis containing vaccines, but rotavirus vaccine also followed a similar trend. But because of the age limitation where a rotavirus vaccine can be given, there is a short follow-up. So we cannot follow up them until like 15 months or 17 months. So we are not showing the rotavirus vaccine coverage, cumulative coverage here. So generally from these analysis from the comparison of monthly and cumulative coverage, we can say that vaccines given at older age had a greater impact due to the pandemic than those given at the younger ages. Now, so that's it from my side. Now I'd like to request Shannon to move forward with the mid-time poll questions and continue her part of presentation. Thank you.
Thank you very much, Yuba. So Lydia's going to go ahead and put up, we have 2 poll questions to see who's paying attention, I guess. So the first poll question, childhood vaccines given at younger ages in Alberta showed a larger decline during the pandemic than vaccines given at older ages. Is this true or is this false? All right, Yuba, what is the correct answer?
So childhood vaccine given at younger ages in Alberta showed a larger decline. So younger ages, yeah, it's false. It's the correct answer.
Yeah. So it's actually the older ages that were had a greater impact. And we think that probably reflects the fact that the primary infant series was prioritized. So they were really making an effort to get those first 2, 4, 6 month doses done. And then the second poll question. Among early childhood vaccines, which vaccine shows the largest gap in coverage after 1 year of follow-up? So this is the latter part of Yuba's presentation, looking at cumulative coverage and who got caught up. So which vaccine shows the largest gap in coverage after 1 year of follow-up? This is, I think the correct answer, correct me if I'm wrong, Yuba, is MMR, although the 4th dose of pertussis containing vaccine might be a strong contender for a gap. So yeah, so again, it's the older ages. So the MMR at 12 months and the 4th dose of pertussis containing vaccine that really lagged behind. Okay, thank you. Okay, so I'm going to share with you a little bit of preliminary data on the impact of the COVID-19 pandemic on school vaccine uptake. This information draws from publicly available aggregate data provided by Alberta Health. For any of you that are interested, this is available on the Alberta Health website. Our team is in the process of doing more detailed analysis using individual level data from Alberta Health, similar to what Yuba presented to you for the infant vaccines. So here we have results for the 2 vaccines routinely provided in grade 6 in Alberta schools, which are HPV and hepatitis B vaccine. This chart shows a comparison of coverage for 12-year-olds in 2019 in the gray bars versus 12-year-olds in 2020 in the dark, I guess it's a dark gray. So the darker bars. So starting from the left, we see hepatitis B vaccine dose 1 and dose 2. And you see the coverage of the second dose for hepatitis B vaccine in 2020 dropped significantly compared to 2019. So it went from 72.6% in 2019 to 28.1%. That's reflecting very much the fact that schools in Alberta shut down in the middle of March, and a large number of children did not yet have their second dose received. HPV vaccination seems to have been impacted the most among all childhood vaccinations. The coverage of the second dose coverage for HPV vaccine in 2020, so those are the 2 bars on the right, was greatly reduced. So the publicly available data splits up female and male coverage. So that's why we have 2 sets of bars for each dose. So if you look to the far right, you can see HPV dose 2 in males went from 62.9% in 2019 down to a dismally low 7.9% in 2020. So we have a lot of catch up that is required there. We also wanted to have a quick peek at what was going on with our CatchUp program that happens in grade 1. So this slide shows coverage for pertussis containing vaccines, measles, and varicella. In Alberta, Public Health does a CatchUp program for kids in grade 1. So they go in, they assess vaccination status, and then they catch kids up. It's a little bit different than what you have in Ontario, where this is really done on school entry. So CatchUp of infant immunizations for children in grade 1, which is 6 years old or so, 6 to 7 years old, didn't show as much as a decline as the older school-based immunizations. And that's partly because those are being caught up throughout the year. So a number of those kids would have been caught up in the fall before the pandemic arrived. And then there was also a real concerted effort to catch these kids up during the following summer. So you can see the impact is much less significant. So we just wanted to wrap things up by talking a bit about what strategies were used for CatchUp in Alberta. We We had done an environmental scan of all the provinces to find out what the plans were. And then we went back to Alberta to find out what they actually did in practice once the pandemic was underway. So infant vaccine strategies for CatchUp. So this is a key point that I think is a real good news story that Yuba highlighted already, that after the initial reduction of vaccine service delivery at the start of the pandemic, many of the community health centers were actively contacting parents of 6-month-old children to get them vaccinated before their child aged out of rotavirus vaccine eligibility. So that means that those kids were coming in to get their 3rd dose of rotavirus and also were getting their 3rd dose of their pertussis containing vaccine. And that was a hugely effective strategy. Certainly there's ongoing catch-up strategies that are going to be needed to make sure that kids that have yet to be caught up or have done so, and with public health resources stretched so much, I think there's still work to be done in that area. In terms of the school immunization catch-up, for vaccines missed in the 2019-2020 school year, so that's the first school year of the pandemic, catch-up was offered through the regular school-based program in schools in the following year. So public health nurses were going into schools in the fall of 2020 to catch up kids. And some zones of Alberta also held mass catch-up clinics throughout the summer between the 2 school years. And public health nurses have really pushed to complete the 2019-20 cohort. And then we'll be moving on to catch up the following cohort. And again, these kids are not quite caught up. And the work that we're doing now to look at school vaccine coverage is to do that cumulative coverage analysis where we're seeing whether these kids eventually get caught up. So in the 2020-21 school year, public health nurses in Alberta were able to go into most schools when the school-based programs were running. If there was an outbreak declared in the school, they weren't allowed to go in and they had to reschedule their immunization day. So it was a little bit of on again, off again in trying to get these programs rolled out, which certainly impacted coverage. Parents could also take students to public health clinics to be immunized. And those students who were attending online, so weren't in in-person classes, they could either come to school for the immunization day or go to the public health clinics to get vaccinated. And some school boards arranged specific places for homeschooling students to be immunized, for instance, at the school district office. The grade 9 program was prioritized in particular because in Alberta, school immunization programs don't serve high schools. So in Alberta, kids transition from junior high to high school when they enter grade 10. And so they were trying to make sure the grade 9 programs, so for instance, the meningococcal vaccine, that they were catching up these kids so that they didn't have to figure out how to roll out a program in a high school that had never had a vaccine program before. And nurses were going in on alternate days. So there was a lot of, just trying to go as frequently as possible to try and reach kids that were absent at the previous visit. So in terms of future catch-up plans for a school immunization program in Alberta, again, some zones have held mass catch-up clinics throughout this past summer. Public health nurses have been pushing to complete the 2019-20 group and then move on to the 2020-21 group. So we've got a little bit of a pile up happening that they're having to work through. And they're trying to catch up missed doses in grades 1 to 3 first, just to make sure that those primary series are completed, and then following with the grades 6 to 8. So that is the end of our presentation. Just some thanks to our team that have been instrumental in this project and in preparing this presentation. And my contact information is there if anybody wants to reach out. We've been asked to provide the references. And we are happy now to turn it over to the question and answer period.
Well, thank you very much, Shannon and Yuba. We will now move to the Q&A pod to address any questions. Please feel free to enter your questions into the pod if you have not already had an opportunity to do so. I'm wondering whether I could just pose a few questions based on your presentation, which was very informative. So in Alberta, compared to Ontario, is it correct that the childhood immunizations are administered by the public health units rather than the primary care physicians and staff. Is that correct?
Yes, sorry, I should have clarified that right at the beginning. So I hope that didn't leave anybody in the dark. Yeah, in Alberta, we have quite a different approach. Essentially, all early childhood vaccinations are provided exclusively by public health nurses. So in community health centers by public health nurses for the 2, 4, 6, 12, 18 month and preschool visits. The only exception would be influenza vaccine, which is now being provided in pharmacies for kids older than 5 years old. And then school vaccines also, so they're provided in schools. And if kids can't get it in school or don't want to get it in school, they would go to public health. So physicians are not involved really in that process at all.
Okay, thank you. And follow up to that question, an audience member asked, curious to know how you have worked with primary care providers to complete these immunization catch-ups.
So I can't take any credit for it at all. I'm reporting on what other people are doing in their efforts. So our team is really interested in identifying what strategies have worked and which have been less successful. So we've certainly been speaking with public health to find out what's been working. Primary care providers, I think maybe is I just want to reread the question to make sure I'm understanding here. Yeah, so right now, primary care providers, if by that you mean physicians, family doctors, pediatricians, or whatnot, as I said, are not really part of the routine immunization program. It's just not the process that we have in Alberta. There's certainly pros and cons to that approach. I mean, in a scenario like now where, you know, all hands on deck, we want to vaccinate as many kids as possible, I can see there being maybe the need to get more providers in, but it poses some challenges in terms of accessing vaccination records and entering vaccination data. So the upside of having a single provider of vaccination is that our immunization records for Alberta are entirely complete. So we can go into a provincial database and see every single child and every single vaccine without having to collect data from multiple sources. So I'm not sure if that's a useful answer. Basically, primary care providers are not actively involved in this.
I think as an extension of that is more wanting to see if the primary care providers, which would include physicians, nurses, NPs, because you do mention in one of your slides about community health centers also offering like mass immunization clinics to try to catch up on the childhood immunizations, whether they were at least played a role in terms of advocating for or reminding parents and families about the need for their children to get vaccinated, not necessarily administering the vaccine.
Yeah. So, okay, thanks. That's a good point. So, and we've done some work looking at this in Alberta, because we found that even though physicians are not providing the vaccines, if a child has a regular physician, they are more likely to be vaccinated. So even though, you know, family docs and pediatricians are not providing the vaccines, if they have, I suspect it's because if you have sort of an established trusting relationship with your physician, and if they're having those kinds of conversations, even though they're not the ones providing the vaccine, those kids are getting vaccinated. But that's a bit of speculation on our part. And maybe this is a time for us to maybe think more about the role of those primary care providers that are not currently providing vaccination.
Okay, thank you. Now, as you are aware, there is going to be a roll-up of COVID vaccines for the children ages 5 to 11. And there is a question, do you have any thoughts on what may be the most effective COVID-19 rollout for children? There it says 4 to 11, but 5 to 11, public health or primary care?
So again, I'm not in any sort of policy position, but I can say sort of what's been what I would see as being appropriate. So because pharmacists in Alberta are permitted to vaccinate children 5 years and up, certainly with influenza vaccine, and they've been instrumental in delivery in COVID vaccine. I can see there being a big role for pharmacy in delivering COVID-19 vaccination to that age group of 5 to 11s. I'm not actually sure what the provincial plan is in regards to primary care physicians in providing the vaccine. I'm fairly certain that public health will continue with providing COVID-19 vaccines either in the public health centers or in the mass clinics. And I know my 11-year and 8-month-old daughter will be first in line to get that vaccination for sure.
All right, so just a few more questions that have come up into the Q&A. Are there any organizations, bodies of knowledge that public health professionals can point to as a resource to patients and or teams to support translating this information need to have vaccinations up to date?
Okay, don't take that off the Q&A yet, Diane. I need to read it.
Yes, it was a good question.
Yeah, it is a good question. I think so. It's really about knowledge translation and getting getting the message out and advocating for vaccination. And I know I've been involved in quite a bit of work around improving vaccination in traditionally underserved populations. And what we found really most effective is that people who come from those populations, who are members of those populations, really need to be the champions. So I often will sit on a panel where, I can provide my perspective as a researcher, but that I'm not the trusted voice. So having people in the community that is trusted. So for instance, I've done work with the Métis Nation of Alberta where I'm there on the panel, but really it's the Métis health leadership that are who the membership are interested in hearing from. So I think we just need to really engage with communities and ensure that the message is coming from the right people. And then of course, having the right information available. And I think we've been finding that, having information available in language of choice is a critical component so that people can read about the information in the language they're most comfortable in. I'm feeling bad because none of these questions relate to all the hard data analytic work that Yuva has done.
Well, I'm just going to ask a question now regarding that. I'm wondering whether you did actually have an opportunity yet to study the actual, are there any demographic differences, socioeconomic differences, geographical differences in terms of coverage rates across Alberta? Has that data started to be analyzed? And if so, are you able to comment on anything that has been observed from that analysis?
I don't know, Yuba, if you can comment.
Yeah, in this analysis, we did not analyze by those characteristics, but definitely we can look at in the future what is affecting, what is the factor that's determining the vaccine coverage among infants. Yeah.
Okay. And then to build on that question, I was wondering now that the COVID vaccines are going to be rolled out to the 5 to 11-year-olds, and then also now we're into the influenza flu season, how do you anticipate that's also going to have an impact on the routine childhood immunizations, as well as the school-age vaccinations, especially in the context of staffing resources, if it's the public health unit that's primarily the providers of these vaccines?
Yeah, I think that's a great question because we've certainly seen that health professionals are a finite resource. We've seen it certainly in acute care, and we're seeing it in public health as well. So I think it's going to be important to be strategic about who's providing the vaccine. So for instance, if we've already got pharmacists and physicians, scaled up and ready to give COVID-19 vaccinations, maybe that should be their primary mandate. And perhaps public health, the public health nurse's primary mandate is to make sure the routine vaccinations are up to date. So I think there's a bit of sharing it around, right? Because public health, my colleagues in public health, I can't say enough about how they've managed to fit all this in with screening and testing and vaccinating, et cetera, et cetera. So I think strategic use of the breadth of public health and other health services is going to be critical.
All right. Thank you. I don't see that there are any further questions in the Q&A box. If anyone would like to provide any further questions, please feel free to our speakers. Otherwise, I think we would like to wrap up today's public health round session. I would like to thank Shannon and Yuba for presenting. I would also like to thank anyone who joined us for today's session. It's great to see such a strong virtual participation during such a challenging time for healthcare professionals. You can expect to receive the brief and anonymous PHO round survey for today's session. Please try to complete this to help us improve our programming. Lastly, to access past PHO rounds presentations and view confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you, and have a wonderful day.